Okay. So today is November 16, 2023. So we will have this small group discussion from 10 to 12:30. I hope we can finish it earlier. Okay. So mentees, about 6 of you. Okay. So learning objectives. Given the patient, the mentees will provide details, clinical data clearly and concisely, as much as possible, relevantly, okay? Provide a good history and present a complete examination as one would proceed in the bedside's preceptorial, again, relevantly. Give differential diagnosis and explain how the group arrived at the primary working impression. So do it in an efficient manner. Explain the pathophysiology of the disease at hand and may include the theoretical data or possibly existing and epidemiology of it. Again, I would like to emphasize to do it relevantly, focus, provide options for additional diagnostic maneuvers or studies, provide surgical plans or medical plans or other treatment options as indicated, then present a journal appraisal of the relevant clinical question regarding the management of the patient. Okay. So these learning objectives I got from the syllabus, your syllabus. I don't know whether it's updated or not. No, okay. So that's why I was asking for a copy of the learning objectives. Baka may mga bago, no? Okay. So are these clear to all of us? Clear? Jose?
Yes, sir.
Yes po.
So basically, you will be presenting this one: history, physical examination, differential diagnosis, diagnostic, treatment plan, relevant journals, psychosocial concerns, questions and answer, communication skills, and then presentations. Okay. So I'll be evaluating you based on these parameters. Okay. So for the journal, so these are the guidelines given to me also. Research questions based on the clinical problem related to the management of the case, 5 points. Description of how the article was sought, 5 points. Summary of the journal, 5 points. And then journal appraisal using a checklist based on the type of study, okay, 20 points. Okay. So there'll be individual group grading, okay, although you submitted a one report. Okay, I suppose it's a collaboration of all, but during the discussion today, we'll be evaluating you on an individual basis, okay, through answering questions of the facilitator and asking questions to me. So mainly through active participation. Okay. Okay. Yeah, I just suppose that all of you contributed to the case and case discussions, presentation, and journal. Okay. So as to the faculty, you have to evaluate me based on this one. Okay. I don't know whether you have a list of this one. Okay. The teacher, that's me, explains the objective, which I'm doing now, expectations and various requirements of the course of the session, encourages students to think critically and or creatively, communicate clearly, answer students' questions clearly and adequately, help students understand complex ideas related to the subject matter, uses engaging and helpful learning exercise and activities, relates the subject matter to issues and development in discipline, okay, or real-life concerns, encourage students to participate in the discussion, make himself available for consultation. I'll give you my email and also my Facebook account later on. Encourages students to express their ideas and viewpoints, communicates, interacts with students in a positive way, shows respect for student diversity and individual differences, makes full use of the required hours of learning, provide fair and timely feedback on students' performance, uses clear criteria to evaluate students' performance. Okay, I have given you the checklist on how you'll be evaluated already. Okay. So, and then about the use of technology, how the in relation to your learning experience in this class, what does your teacher do that you find helpful and effective? Okay. how does the teacher enhance your learning, and how does it, because you're using Zoom now, how does the teacher utilize technology more efficiently to enhance your learning? Okay. So these are the parameters that you will be evaluating me. Okay. Okay. So I'll make myself available. As I said, my Facebook Messenger is Reynaldo O. Hoson or R.O. Hoson Telemedical Consultation. My email is this one. Okay. You can also Viber me. Okay. Okay. So I have given you a YouTube lecture on patient management process. All of you have read it.
Yes po, sir.
Okay. And all of you have tried answering the OLETE, the online learning curve evaluation test exercise. Lahat?
Yes po.
Lahat, ha? Okay. Okay. So if you pass the OLETE, I'm going to give you a certificate like this. Okay. Okay. So what we're going to do to save time, it's already 10:15 now. I got the report only this morning, so I didn't have much time to read it. The usapan namin ni Franco is last night, di ba? So, tama, na-late kayo, di ba? So, what we're going to do, okay, you just present the case muna, tuloy-tuloy. I won't interrupt the presentation. I'll just jot down my notes, some questions, and then ask those questions later on at the end. Okay? Okay? Is that acceptable to you, that arrangement?
Yes, sir. Thank you.
Sige. Ikaw nang, you take the lead na. You coordinate Jose, Carlos.
Okay po, sir. We'll fix the share screen na lang po, sir.
Mm-hmm. You need the permission? No.
Sir, so si Carlwin na lang po mag-share ng screen. So again, good morning po, sir. We are the Block E interns rotating with GS1. So again, interns R2's Bernardo, Bognot, Chua, Costales, and Fernando. So next slide, please. So just the flow of our discussion as is listed in the format. So next. So we'll begin po with our history of the patient.
Presenting po the case of RS, 65-year-old male, tricycle driver, Roman Catholic from Sampaloc, Manila, presenting with chief complaint of abdominal enlargement. Next slide po. Slide. 10 years prior to admission, patient noted gradual abdominal enlargement, initially soft on palpation, with associated occasional loose stool and early satiety. The patient did not note any abdominal pain, no anorexia, vomiting, dysphagia, melena, hematochezia, or any palpable mass. The patient described this abdomen at this time as soft on palpation with no consult was done. no medication was taken. Then 8 months prior to admission, due to the persistence of symptoms now with associated bipedal edema, patient consulted at a local hospital where whole abdominal ultrasound revealed non-visualized right kidney uh, and was advised for uh, CT scan with contrast. However, on laboratory examination, patient had elevated creatinine. So only a plain CT scan was done, which revealed a retroperitoneal mass with aggressive features, uh, approximately the size of 25.2 by 16.3 by 17.8 centimeter. The primary consideration is retroperitoneal liposarcoma, obstructive nephropathy, right? Patient was advised to take ketoanalogs and furosemide. Next slide. In the interim, noted gradual enlargement of the abdomen, still with bipedal edema and loss of appetite, and documented weight loss, early satiety, and difficulty of breathing on exertion, probably restrictive from the abdominal enlargement, loose stools, and lower urinary tract symptoms such as intermittency, dribbling of urine, and nocturia. Then 2 months prior to admission, due to the persistence of symptoms and now with associated back pain, patient sought consult at PGH OPD where abdominal CT scan with IV contrast was done, showing right retroperitoneal complex mass, highly suggestive of liposarcoma with right renal involvement and mild hepatobiliary ectasia, minimal ascites, mild bilateral hydrocele, and on PE, there's enlarged descended abdomen with palpable non-tender mass, and on DRE, also revealed estimated prostate size of 30 grams with no palpable nodules. The patient was started on tamsulosin 400 microgram per tab, once a day at bedtime, and finasteride 5 milligram, one tab once a day at bedtime. But patient only took 4 tabs of tamsulosin and allegedly did not take finasteride. On the day of admission, patient noted severe back pain and difficulty of breathing on exertion, thus seeking admission for possible surgical management. Next slide. For the review of systems, a patient is cachectic, described as mas pumayat lalo. However, the weight loss was undocumented po. Unintentional weight gain because of the enlarging abdominal uh, because of the enlarging abdomen po. Anorexia with a productive cough, no night sweats, no fever, no colds, with dyspnea on exertion, no orthopnea, no PND, with occasional nape pain, no headache, no dizziness, no chest pain, no palpation, with lower urinary tract symptoms such as nocturia and complete emptying, weak stream, straining, no dysphagia, no odynophagia, no abdominal pain, constipation, diarrhea, hematochezia melina, bloating, no polyuria, polydipsia, polyphagia, no dysuria, hematuria, oliguria, and with back pain. Next slide. For the past medical history, patient is hypertensive since 2015, maintained on losartan 50 milligram once a day and amlodipine 5 milligram once a day with good compliance. Usual BP ranges from 100 to 70. Highest BP was 200 over 100. Patient is also CKD stage 4 since diagnosed since March 2023. And patient is hyperuricemic, maintained on febuxostat 40 milligrams, one tab once a day. Also with history of pulmonary tuberculosis, diagnosed last 2022. Status post PTB regimen 1, treatment interrupted after 3 months. Other meds taken by the patient, ferrosulfate plus folic acid, vitamin B complex, and omeprazole. No known DM, no asthma, no cardiac, liver, or thyroid disease, no um, myocardial infarction, no stroke, no known allergies to food or medications, no previous surgeries or major trauma. Patient is fully vaccinated against COVID-19 with one booster po.
So for the next part, the patient's family medical history. So most notably, the patient the patient's mother had pulmonary tuberculosis, and they would live in the same household. Uh, when it the patient's mother and father, as well as his older brother, also had hypertension, and this older brother also had a stroke. So uh, these are the pertinent conditions in the family medical history. Uh, Other conditions such as MI, diabetes, asthma, COPD, etc., were not present in the patient's family medical history. For the personal social history, the patient was a previous smoker with a smoking history of 10 pack years. He was also a previous occasional but heavy alcoholic beverage drinker, drinking to intoxication for about 40 years since he was a teenager, stopping only a few years ago, and the patient denies illicit drug use. So for our physical examination, when we examined the patient, he had a blood pressure of 110 over 70, heart rate of 80, respiratory rate of 20, temperature 36.2, and oxygen saturation of 100% on room air, so uh, not oxygen requiring. He has a BMI of 16.6, so that would qualify him as underweight. The patient was awake, alert, oriented, cachectic, but not in any cardiorespiratory distress. Uh, he had anecteric sclerae. The rest of anecteric sclerae, slightly pale palpebral conjunctivae. Notably, he also we observed temporal wasting on the patient. Uh, the patient's lungs, chest, he had equal chest expansion. No retractions noted, but we were able to auscultate fine bibasal crackles, and but we had no wheeze. For the cardiovascular PE, a dynamic precordium, distinct heart sounds with normal rate and regular rhythm. Apex beat is not displaced, uh, and no murmurs, heaves, or thrills. And then for the abdomen, so we have pictures po of the abdomen in the next slides, but uh, let us describe this first. So he had a distended but non-tender abdomen. The upper hemi-abdomen above the level of the umbilicus was firm. Below this level, the abdomen on palpation was soft. Uh, he had normal active bowel sounds, and the abdominal girth was 100 centimeters. His abdomen did not have any skin discolorations. There were no open wounds, but we were able to note a dry, well-packed post-biopsy site on the right hemi-abdomen. The biopsy happened 2 days before we examined the patient. We also noted costovertebral angle tenderness, more on the right side of the patient. Okay, and then for the extremities, he had full and equal pulses, capillary refill time of less than 2 seconds. We also noted grade 2 bipedal pitting edema. And for our DRE, most notably, we were able to palpate the prostate and estimated it to be around 40 grams in size. But there was a good sphincter tone, no lesions or fissures observed, no masses or nodules palpated, no tenderness, and only stool per examining finger, no blood on examining finger. So for the next slide, here is an illustration of the distended abdomen of the patient with the note of the post biopsy site, which is packed and dry. So this is the front view. Next slide. So here is the lateral view of the patient's abdomen. So notably distended. Again, with an abdominal girth of 100 centimeters. Next slide. This is the other side. So we have an image of the well packed, dry, and no leakage, no bleeding, no purulent liquid coming from the post-op biopsy site. The next slide, and this is the patient's posterior, his backside. Uh, no lesions, no other remarkable findings for the path.
For the next part, we'll shortly go back to the patient's presenting complaints as well as the pertinent subjective and objective information about the case. So again, we have a 65-year-old male known hypertensive, no prior surgeries, presenting with a 10-month history of abdominal enlargement. So for the pertinent subjectives, we have an enlarging abdominal girth, GI symptoms such as loose stools, early satiety, and anorexia, as well as bipedal edema, nape and back pain, lower urinary tract symptoms like tripling and nocturia. However, there are no noted fever and night sweats. So for the objective findings in this patient, we appreciated a palpable non-tender abdominal mass, an increase in abdominal girth, notably from 90 cm during the OPD consult up to 100 centimeter upon physical examination upon admission. So on DRE, again, good sphincter tone, no masses palpated, no nodules, no tenderness, with an enlarged prostate of around 40 grams, but no blood on examining finger. So pertinent negatives on the PE, there are no displaced apex peak, no distended neck veins, which is important on the discussion on the later parts. There are also no palpated lymphadenopathies. Next part, please. So here, considering that the patient predominantly presented with an increase in abdominal girth, so going back to basics, what we were taught was in distended abdomen, we can first think of these six. So first is the fluid, fat, feces, flatus, fetus, and a flipping big mass. So next slide, please. So for this patient, first fat, so we got the patient's BMI po. The patient's BMI was 16.6 and he was considered underweight. However, in cases like for this patient, they even though they are seen in the physical examination a while ago, the patient was cachectic but had an unintentional weight gain of around 9 kilograms, which can be attributed to the size of the mass. Then for the flatus, so its absent may signify an obstruction in the bowels. However, the patient was noted to have feces and flatus naman po up to the day of admission. So we can easily rule out fetus since the patient is a male. For the fluid, it can be secondary to a liver disease, but sometimes congestive heart failure. So based on the history and PE, the patient is a known hypertensive. However, for around 8 years, however, the patient did not present with usual signs and symptoms of heart failure. So aside from the dyspnea on exertion, so there was no noted orthopnea. There was no noted orthopnea, and on physical examination, there are no distended neck veins, non-displaced apex peak. So another consideration for this one is this could be a liver failure. However, there are no signs of liver failure also in this patient. No history of jaundice. On physical examination, the sclerae was not icteric. No spider angioma, palmar erythema. And so upon workup, we appreciated a big mass on the abdomen, retroperitoneal indication. So in this case, the most likely culprit is the mass for the abdominal distension. Next slide, please. So again, with the abdominal CT with IP contrast done here in our institution, the patient was seen to have a right retroperitoneal complex mass, highly suggestive of liposarcoma with right renal involvement, and mild hepatobiliary ectasia, minimal ascites, and mild bilateral hydrocele. So combining this, combining our history in PE, as well as the benefit of this imaging prior to admission, we can formulate our primary clinical diagnosis as a soft tissue tumor, likely a retroperitoneal sarcoma. So next slide, please. Next slide. So retroperitoneal sarcomas po are rare cancers representing 0.2% of cancers in adults with an average annual incidence of only 2.7 cases per million. So due to their retroperitoneal origin with large potential spaces, so the tumor can enlarge gradually and only present with symptoms once it is big enough to encroach on surrounding structures. So this is the case of the patient wherein upon detection, the mass was already around 20 cm in dimension, and he was already presenting with symptoms such as early satiety, abdominal pain, loose bowel stools, back pain, since 10 months ago. Next slide, please. Next slide, please. So here are possible other differential diagnosis for a retroperitoneal tumor lifted from a journal. So we consider this more of the neoplastic side because of the fast progression of symptoms of the patient as well as the growth of the mass. So neoplastic, so primitive likely sarcoma. So our secondary, it can also be a lymphoma. However, the patient did not present with usual symptoms of lymphoma such as your B symptoms, your fever, night sweats, weight loss. It can also be a renal tumor. Considering the patient's age, smoking history. On the next slide, we can compare and contrast our main differentials. Next slide, please. So for here, we try to summarize for the usual findings on our primary clinical diagnosis as well as our differential. So in retroperitoneal sarcoma, commonly seen in the 5th decade of life, it is also the same with lymphoma and renal neoplasm, wherein it can be common in the 5th to 7th decade of life. So no sex preponderance in sarcomas, but both in lymphoma and renal neoplasm has a male preponderance. So all of them can present with palpable mass. However, when the mass is that big in the abdomen, I read that it is most likely a retroperitoneal sarcoma. Then for the abdominal pain, in cases of retroperitoneal sarcoma, it can be secondary to mass effect on surrounding neurovascular structures. In lymphoma, abdominal pain is the most predominant symptoms, noted up to 77% of patients, while in renal neoplasm, pain is more common in the flank. So in terms of urinary and bowel changes, again, it can be in retroperitoneal sarcoma, it can be secondary to mass effect on surrounding structures, can also be present in lymphoma. However, in renal neoplasm, they mostly present with hematuria only. Constitutional symptoms are common in all, however, more predominant in lymphoma. Bipedal edema is uncommon in lymphoma, but in retroperitoneal sarcoma, it can be secondary to impairment of venous return, and in renal neoplasm, it is common if with involvement already of your inferior vena cava. In GI bleeding is uncommon in sarcoma and neoplasm. However, in GI lymphoma, it can present in up to 0 to 30% of patients. Okay, so again, our primary clinical diagnosis based from our history and P as well as the pre-admission imaging done is your retroperitoneal sarcoma, and secondary clinical diagnosis of lymphoma or renal neoplasm.
So moving on to the diagnostics. Next slide. Here we can see the certainty and proposed treatment of our primary and secondary diagnosis. So given the patient's age of 65-year-old and month history of abdominal enlargement with signs and symptoms of back pain, bipedal edema, urinary and bowel changes, as well as constitutional symptoms such as early satiety and weight loss, supported by the P findings, the mass points more to a malignant etiology. So for this case, we are considering a retroperitoneal sarcoma, a lymphoma, and a lymphoma. So since we are still not certain po on what type of malignancy the patient may have, we can only say po that we are 50% certain for both diagnoses. According to studies, retroperitoneal sarcomas are rare, with an annual incidence of 0.76 new cases per 100,000 people. So colorectal lymphomas are also considered rare etiologies, accounting for only 0.9 to 1.2% of all colorectal malignancies. But since we are dealing with a retroperitoneal mass, still the two most common causes are the lymphoma and liposarcoma. With this, paraclinical diagnostic procedures, most importantly, imaging studies must be performed to evaluate the mass, identify its location, and determine the extent. So imaging findings allow us also to narrow down the differential diagnosis and decide on the appropriate management. So for liposarcoma, the excision of mass is the primary treatment modality, whereas in lymphoma, a chemoradiotherapy is more beneficial. So next slide, please. So for the paraclinical diagnostic procedures, we have the CT scan of the abdomen. So for the benefits, this would help us define the extent of the tumor and its relationship to surrounding structures, particularly vascular structures, as well as for surgical planning. Certain features on CT are considered markers for malignant behavior, would include margin irregularity, infiltration into adjacent organs, calcification, necrosis, and hypervascularity. So with this imaging, we can also narrow down our differential diagnosis based on the imaging characteristics such as fat, calcification, and necrosis. This is also helpful to evaluate evidence of metastasis, such as in the liver, as well as the kidney function. So what are the risks of CT scan? So this is a non-invasive procedure. However, for this case, we have to take note that the patient is a known case of CKD and there is still a risk for contrast-induced nephropathy. As for the cost, I looked it up. The cost ranges from 13,000 to 25,000, but here in PGH, it's around 9,385 pesos. And it's widely available in tertiary hospitals or in an outpatient facility. Second would be the core needle biopsy. This is still considered the gold standard in the diagnosis of liposarcoma. So this can differentiated from the differentiated liposarcoma, wherein the latter would benefit more with the neoadjuvant chemotherapy. However, a well-differentiated liposarcoma may be diagnosed with CT imaging alone, and negative biopsy findings should not delay operative intervention. So as for the risks, still it's invasive, but it's found to be safe naman. The rare complications include pain, bleeding, and inadvertent organ injury. For the cost, it's around 3,600 to 8,000 po in private hospitals, and it's available also in tertiary hospitals. So next slide, please. Focusing po on one paraclinical diagnostic procedure, we have here a contrast-enhanced CT, which is a widely used diagnostic modality for retroperitoneal mass, such as in our case. So this will help us clinch our primary diagnosis, which is retroperitoneal liposarcoma. So what we have to look for po? So findings of intralesional fat in CT scan could help us shorten our list of differential diagnoses. So it points more to a liposarcoma. So in contrast to lymphoma, or retroperitoneal liposarcoma is usually visualized as a large encapsulated mass containing variable amounts of fatty and soft tissue components. Okay, next slide. So moving on to the diagnostic procedures done in this case. So this is the contrast-enhanced CT scan of the abdomen done last September 28th. So this is a multiple axial tomographic section of the abdomen with IV contrast. So the findings reveal a 26.8 by 23.5 by 23.9 cm of heterogeneously enhancing solid mass, and with central necrotic solid component and peripheral complex, predominantly fatty component in the right hemi-abdomen, which supports our primary impression of liposarcoma. So for the impression, there is right retroperitoneal complex mass, highly suggestive of liposarcoma with right renal involvement and mild hepatobiliary ectasia, mild bilateral hydrocele. So other diagnostic procedures done were core needle biopsy. So an ultrasound guided biopsy was done for tissue diagnosis last November 10th for this case, but the result was still pending. So the initial findings revealed an atypical round spindle proliferation and a necrotic background. Other so next, other diagnostic procedures done were chest CT scan and bone scan. So considering the large mass with aggressive features in the imaging study, so it's important to assess also for metastasis. So for liposarcoma, dominant pattern is hematogenous and lymph node metastasis is considered there. And in studies, 11% of patients with retroperitoneal sarcoma would present with synchronous metastatic disease. So here we are trying to rule out metastasis. So we did a chest CT scan and bone scan were done in this case. However, there are still no results po. So given po this diagnostic procedures, CT scan findings, the current plan for this patient is surgical excision po of the mass. And to discuss more on management po. Next.
So for the treatment, next slide please. So first is the pre-treatment diagnosis. Our primary clinical diagnosis is soft tissue tumor, likely retroperitoneal sarcoma. And our secondary clinical diagnosis are colorectal lymphoma or renal neoplasm. For the treatment goals, is first is to achieve the complete surgical resection, maximizing clearance of disease, while balancing morbidity and an intimate understanding of the anticipated outcomes after surgery for the histologic type of retroperitoneal sarcoma. And second is to achieve symptomatic relief with realistic expectations for potential immediate late complications, oncologic outcome, and changes to quality of life brought about by the disease. So for the treatment modality, the treatment of choice is the excision of the retroperitoneal mass with tumor resection with the considerations of the patient age and comorbidities, which also should be considered when determining whether to proceed with resection. Medical risk assessment and optimization should be also considered before the operation. If the decision is to move forward with surgery, optimization of any pre-existing medical morbidity should be done with the primary care provider and if needed with medical subspecialties like nephrology, cardiology. So in particular, in anticipation of possible nephrectomy, patients who are at risk of renal insufficiency may benefit from split renal function testing and if needed, pre-operative evaluation with a nephrologist. So malnutrition is also an important issue to recognize and optimize preoperatively to avoid the negative impact on post-operative outcomes. So on radiation therapy po, a prospective clinical trial, RESTRAS, showed no improvement in recurrence-free survival for RPS in general. For chemotherapy, retrospective data to suggest that adjuvant chemotherapy offers no benefit in retroperitoneal sarcoma. So for the benefit risk cost availability of non-operative, which is the radiotherapy, studies suggest that radiotherapy has little or no proven benefit and not associated with improved survival, reduced recurrences for retroperitoneal sarcoma. For the risk, common side effects like skin changes, erythema, pruritus, dryness, nausea, vomiting, or diarrhea changes in stool. And if and it is approximately 2,000 per session, and its availability is it's already available in tertiary specialized hospital in the country. So for operative, will be discussed by Maki po.
So for when we're talking about sort of the operative assessment for the patient, so surgery is the mainstay treatment in primary RPS for all subtypes. And what we would want, as mentioned by Carlwyn, is a full resection of the primary disease, which is in turn helping patient morbidity and mortality. However, some side effects of operative assessments of the patient include bleeding. That's what's one of the biggest problems. There is an expected great amount of blood loss and fluid shifts. Postoperative third spacing into the retroperitoneum, given the sort of the mass occupying size of the lesion. Post-operative ileus, possible renal dysfunction or failure, incisional hernia, and vascular graft thrombosis in the setting of a major vascular resection. In terms of pricing, this is very dependent on the center. If the patient were to go to a private versus public institution, and also price dependent on the extent of surgery. Based on the most recent 2023 PhilHealth RVS codes, depending on the sort of the extent of the surgery, the price can range from 37,000 to 53,000 for the case rate, and the professional fee ranging from 21,000 to 29,000. And lastly, the healthcare institution fee ranging from 16,000 to 24,000. And this is all sort of hinging on the fact that the patient has a working sort of PhilHealth at the moment. Lastly, for availability, it's for operative cases, it's most likely only available in tertiary medical centers with available and capable surgical oncologists, as well as the availability of a multidisciplinary team of sarcoma specialists. So this includes medical and radiation oncologists, as well as pathologists and radiologists. Next, decide on how you evaluate the result or outcome of your proposed treatment. So the goal, as mentioned prior, is the complete resection of the tumor. So ideally, you would want negative microscopic margins or R0. However, given sort of the size usually of RPS tumors, complete resection is more or less defined as negative or positive R1 margins. And then primary disease, partial removal or debulking or R2 resection is generally strongly avoided. And this has shown to not sort of really affect oncologic outcomes. And for our last question is, if data are available, present the treatment procedures done on the patient and their outcome. So patient currently has operative plans for assessment. It's quite vague. It's according to the chart, it's only the excision of the retroperitoneal mass. The extent and the sort of the assessment of the full tumor has not been fully explained, and the patient is also currently awaiting a general medicine referral for risk assessment and stratification for her surgery.
For the prevention and health promotion part po. Next slide. We structured this part po based on the problems of our patients. So we tried to explain the problems present in our patient in simple terms po, and give advice on the management and on health promotion po. So for our final diagnosis, retroperitoneal mass, right? Probably malignant, to consider liposarcoma, obstructive uropathy, right, secondary to one retroperitoneal mass, 2 benign prostatic hyperplasia, AKI stage 2 post-renal from obstructive nephropathy, BPH in retention, and retroperitoneal mass on top of probable CKD stage 3, non-dialytic, non-uremic, hypertension stage 2 controlled, pulmonary tuberculosis clinically diagnosed, status post regimen 1, treatment interrupted after 2 months. Next slide.
So for as how we will advise the patient on the prevention and promotion of health, of course, we have to help the patient understand what the disease is, how it develops, and how it develops the symptoms. So first, for his retroperitoneal mass. So retroperitoneal masses or retroperitoneal sarcomas, these can be asymptomatic until they grow large enough to compress or invade the surrounding structures. And the most common treatment with the potential to cure is still surgical resection. However, it is possible that depending on the situation of the patient, depending on certain characteristics of the mass, it is possible that a patient might not be qualified to undergo resection. And in certain cases, such as extensive involvement of the vasculature or of the spinal cord, these are some of the relative contraindications to surgical resection. So, so that we know who is qualified and who isn't, it's important for the patient to understand that they have to undergo imaging studies such as the CT scan, MRIs, so that we are able to fully illustrate or describe the mass, the tumor, before we even consider to resect it surgically. And in some cases, if preoperative staging evaluation suggests that there is a high likelihood of positive margins, then uh, preoperative radiotherapy or chemotherapy may also be considered. And the prognosis of this depends mostly on the resectability and the histological subtype. So when you say prognosis, we this includes things like other comorbidities or other events that occur. Will the tumor recur after how many years, etc., etc. So again, this really depends on the how well the tumor is resected and the histological subtype. And of course, as with any condition, close follow-up is needed, especially after a surgical resection. So these are just some of the points with regards to the primary problem, which is the retroperitoneal mass. So next slide.
Next would be the AKI from the obstructive uropathy. So first, we would explain to the patient what obstructive uropathy is. So obstructive uropathy is a disorder of the urinary tract that occurs due to urinary flow obstruction, which can either be structural or functional. And in our patient, it's most likely due to a structural cause from the mass effect of the enlarged prostate and from the retroperitoneal mass because of its uh, proximity to the urinary tract. So it can present with abdominal and flank pain and lower urinary tract symptoms, which is very evident for our patient. And and because of the restriction in the urinary flow, the urine backflows to the kidney, which causes also dilatation within the tract. And over time, this can cause damage to the kidney, which can be irreversible, depending on multiple factors, which also places great importance in prompt diagnosis and treatment of obstructive uropathy in order to prevent irreversible damage to the kidneys. And also, we have to advise the patient that there is an increase in development of UTI because of the urinary stasis. Next. And for the benign prostatic hyperplasia, it's the enlargement of the prostate gland, which may potentially slow or block the urine stream again because of its close proximity to the urethra. And we have to explain to the patient that enlargement of prostate is normal to some degree in men with advancing age, and risk factors would include a family history of benign prostatic hyperplasia and physical inactivity. So most common symptoms again seen in our patient would include urinary frequency nocturia, interrupted or weak urine stream, and leaking or dribbling of urine. Treatment may include medical management if mild, or surgical if with moderate or severe case. We can also offer lifestyle modifications such as limit of intake of fluids prior to bedtime, reducing consumption of mild diuretics such as caffeine and alcohol, and also training pelvic floor muscles to aid in urgency symptoms and avoid medications that may cause urinary retention such as diphenhydramine, hydramine, and decongestants, and also to practice double voiding. For the medications, we can offer alpha blockers, which relaxes the muscle of the prostate and the bladder neck, which allows urine to flow more easily, and also alpha reductase inhibitors, which can stop prostate from growing further, or even cause it to shrink. So if medications are not effective in alleviating the symptoms of the patient, we can offer surgical management to remove or destroy some of the prostate tissue. And also, we have to advise the patient that um, having BPH does not increase the risk for prostate cancer. However, BPH and prostate cancer may occur at the same time. So we can recommend screening for prostate cancer with PSA levels. So PSA levels may also be increased in patients with BPH. However, for patients with prostate cancer, it's highly elevated po. And also highly elevated PSA level would warrant further testing to rule out prostate cancer. Next slide.
So since our patient also has hypertension and chronic kidney disease, we also have to be able to advise our patient, even if it's even just the basic aspects or whatever the patient might have questions about. So we have to explain to our patient that hypertension is important to manage because it can place anyone at risk for even worse conditions such as stroke, heart attack. And as our patient has chronic kidney disease, hypertension can be asymptomatic, and this is why it's dangerous. It's because it's asymptomatic, so it can affect your organs without the patient being aware of it. However, one of the simplest and most cost-effective methods to treat hypertension is to enact lifestyle changes. So this would include reducing salt in the diet, losing weight, but our patient is already quite underweight, so that might not be a viable option. But again, reducing salt in the diet, avoiding alcohol and smoking completely, and being able to do regular exercise. These are management methods that are free and involve almost little to no risk. So it would be great to advise this to the patient because it might have a good effect not only on preventing hypertension but even on the quality of life of the patient. He might be able to feel better given these minor changes, or well, not really minor, but small changes that may have great effects. Medications may also be given to the patient uh, to prevent the complications of blood pressure and uh, to lower the blood pressure. So we have to emphasize to the patient also that it is important to drink these medications religiously, according to the advice of their physician, in order for the medications to be able to effectively lower blood pressure. And since our patient also has chronic kidney disease, we can explain to him that it is one of the most feared complications of chronic hypertension. And chronic kidney disease is essentially when the kidneys lose their capability to filter blood and remove excess fluid and waste products in the body. And in order to manage this, one of the most important prevention methods is also to maintain good blood pressure, uh, also to improve the diet and restrict salt in the diet, among other things. So yeah, next slide.
Lastly, for this patient, we have to address the pulmonary tuberculosis. So it's important to reiterate to the patient the importance of adherence to the anti-TB regimen for the eradication of TB and also to prevent drug resistance, development of drug resistance. So we, especially for this patient, since our patient is already lost to follow-up, patient already started on anti-PTB regimen. However, after 2 months, patient was lost to follow-up. So for patients lost to follow-up, they have to undergo gene expert MTB reef and also depending on the result, to refer to drug-resistant TB treatment center as needed. And also, we have to advise the close contacts of the patient to be screened for TB based on the presence of signs and symptoms and with use of chest X-ray. And also, we can also evaluate for their eligibility to receive TB preventive treatment.
So moving on to the journal critique portion of our presentation today. First of all, we're going to start with so as we previously presented the clinical case, we're going to first present the search strategy. Then we're going to appraise directness, validity, results, and applicability, and lastly, individualizing the results. So for the clinical case, that was the case that we previously mentioned, and now for our search strategy. So for our clinical question, it's among patients diagnosed with retroperitoneal soft tissue sarcoma, how does initiation of adjuvant radiotherapy alongside surgical resection compared to surgical resection alone improve overall survival and local recurrence? So in terms of how we sort of searched through the articles, we first did a PubMed search. From that, we did a short list of studies. We screened them for usability and quality for our clinical dilemma. And last, that's how we ended up with our study selection. So for our PubMed search, we first searched retroperitoneal soft tissue sarcoma, followed by adjuvant radiotherapy, surgical resection, and lastly, survival and local recurrence. And from these 4 searches, 1 and 2 and 3 and 4, we came up with 67 search results, which we then went through. So from these 67 articles, we excluded 39 articles because these were mishit. So these were either articles just regarding retroperitoneal soft tissue sarcoma, or they did sort of fully encompass the things we would want to see regarding the topic. From there, we landed at 28 articles, and we removed 24 excluded articles because these were either cohort analysis, retrospective studies, or meta-analysis. So this has landed us at a total of 4 articles, which we then selected through. So these are the 4 articles that we sort of assessed and read through. So the first is preoperative radiotherapy plus surgery versus surgery alone for patients with primary retroperitoneal sarcoma. The next is tissue expander placement and adjuvant radiotherapy after surgical resection of retroperitoneal liposarcoma, offering improved local control. Next is surgical resection and radiotherapy for primary retroperitoneal soft tissue sarcoma. And lastly is surgical outcome and patterns of recurrence for retroperitoneal sarcoma at a single center. So for the PIC of the study, we would want for the P or the population, adult patients with retroperitoneal soft tissue sarcoma. For the I, surgical resection plus radiotherapy. For the C, surgical resection, and then for the outcome, survival and local recurrence. So as sort of seen in the table, the first study, which is the preoperative radiotherapy plus surgery, it sort of ticks all the boxes for the comparison to the peak of interest. For the second study, it was looking at sort of tissue expanders plus radiotherapy. So it did not fulfill the criteria of the I and the C. For the third, it was looking at extensive IORT plus EBRT. So it did not fulfill the criteria for the C. And lastly, for the surgical outcome and patterns of recurrence for retroperitoneal sarcoma at a single center, it has no matched cohort. So it was only looking at adult patients with retroperitoneal soft tissue sarcoma and how sort of the surgical resection helped in surviving and local recurrence. So this has ended up sort of narrowed our 4 studies to this one study, which is preoperative radiotherapy plus surgery versus surgery alone for patients with primary retroperitoneal sarcoma, a multi-center open-label randomized phase 3 trial. So this sort of journal was found in the Lancet Oncology, published last September 14, 2020, and the DOI is there also for reference din po.
So for appraising directness po, next slide please. So does the study provide a direct enough answer to your clinical question in terms of patients, intervention, comparison, and outcome? Yes, first, the study aimed to evaluate the impact of preoperative radiotherapy in adjunct to surgery versus surgery on abdominal recurrence-free survival among adult patients with retroperitoneal sarcoma, which is similar to our research question. The study also clearly defined the population of interest as well as their inclusion and exclusion criteria. The intervention with its preoperative radiotherapy as compared to surgery alone, and the outcome in terms of survival and local recurrence between the 2 treatment groups. So for the research question, the population is retroperitoneal soft tissue sarcoma, and the article is the primary soft tissue sarcoma of the retroperitoneal or infraperitoneal pelvic spaces. For intervention, radiotherapy plus surgical resection for the research question, and the article, preoperative radiotherapy plus surgical resection. For the comparison, a research question is for the surgical resection alone, and for the article is surgical resection. And for the outcome, overall survival and local recurrence versus in the article, abdominal recurrence-free survival, metastasis-free survival. Free survival. Next slide, please. So for the patient's profile, the patients is age 18 years or older, histologically documented, centrally reviewed, localized primary soft tissue sarcoma of the retroperitoneal or infraperitoneal spaces of the pelvis, and World Health Organization performance status of 2 or lower, ASA of 2 or lower, normal renal function, normal bone marrow and hepatic function, cardiac function less than or equal to NYHC class 2, and normal 12 lead ECG. Next slide, please. So the table 1 shows the baseline characteristics comparing the surgery alone group versus the preoperative radiotherapy plus surgery group. Next slide, please. So for the procedures, surgical resection alone, multivisceral and block curative intent surgery was done within 4 years of randomization in the surgery alone group versus 4 to 8 weeks from the end of radiotherapy. The goal was a macroscopically complete or 0R1 resection of the tumor. You should have to indicate whether the sarcomatosis was discovered, surgery was macroscopically complete, per-operative tumor rupture occurred, organs that were not macroscopically involved were resected. For radiotherapy plus surgery, preoperative radiotherapy was delivered by a 3D conformal radiotherapy or intensity modulated radiotherapy, done according to EORTC quality assurance. And the radiotherapy was started within 8 weeks of randomization. The prescribed dose was 54 GY in 38 once daily fractions of 18 GY with fractions, 5 fractions per week. So next slide. For the appraising of validity, the first question is, were the patients randomly assigned to treatment groups? Yes, the patients were randomly assigned and randomly assigned centrally at the headquarters of EORTC using an interactive web response system to receive either en bloc curative intent surgery alone or preoperative radiotherapy followed by en bloc curative intent surgery. Randomization was stratified by hospital and World Health Organization performance status 0 to 1 versus 2 using a minimization algorithm and was not balanced by histological subtype. Second question, was the allocation concealed? No. Although the randomization was done by an interactive web response system, concealment of the treatment allocation was not possible due to difference in treatment between the groups. Next slide. Third question is, were the baseline characteristics similar at the end of the trial? So the baseline characteristic presented in table 1, however, the p-values were not provided. Hence, we cannot tell whether there is statistically significant difference between the baseline characteristics of the 2 treatment groups. However, grossly looking at the percentages, each characteristic only differs between the 2 groups by 1 to 7%. For the first question, were the patient's caregiver and outcome assessors blinded to treatment assignment? No, the blinding of treatment groups in this study was not possible due to the differences in treatment. The patient's caregivers and outcome assessors were all aware of the treatment they were getting. Were all patients analyzed in the groups to which they were originally randomized? Yes, the abdominal recurrence-free survival was analyzed between those who received preoperative RT versus those who underwent surgery alone. The surgery alone group underwent surgery within 4 weeks of randomization, while the preoperative RT group underwent surgery 4 to 8 weeks from the end of radiation therapy. Outcomes were then measured and possible time assessment bias was taken into account during the statistical analysis for both groups. And lastly, was the follow-up rate adequate? Yes, shown in figure 1 is the trial profile of the study, wherein we can see that at the start of the study, there were a total of 266 patients enrolled and equal number of patients were randomly assigned to each treatment group. Among the surgery alone group, 128 eventually had surgery and 4 were lost to follow-up, while 124 completed follow-up, which has a dropout rate of 3%. On the other hand, among the 133 patients in the RT plus surgery group, 119 had RT and surgery, and 7 were lost to follow-up, while 115 completed follow-up with a dropout rate of 5%, approximately 5%. The loss to follow-up rates are 3% and 5% for the surgery alone group and the pre-operative RT plus surgery groups, respectively, which is acceptable and less likely to create bias in this study. Next slide, please.
And next is the appraisal of the results po. So first, what is the primary outcome? So the primary outcome for this trial was investigator-assessed abdominal recurrence-free survival. So this was measured from the time of randomization to abdominal relapse or death, whichever occurred first. Abdominal recurrence encompassed various events, including local or distant progressive disease during preoperative radiotherapy, inoperability due to specific criteria, peritoneal metastasis found at surgery, macroscopic residual disease left at surgery, or local relapse after complete resection. Next, how large was the treatment effect? So the hazard ratio is the measure of treatment effect and survival analysis. So in this study, the HR for abdominal recurrence free survival was reported as 1.01 with a 95% confidence interval of 0.71 to 1.44. So this indicates that there is no significant difference in abdominal recurrence-free survival between the surgery alone group and the preoperative radiotherapy plus surgery group. The 95% confidence interval ranges for so the confidence interval suggests that the difference is not statistically significant. So to discuss more, Carl.
So to further elucidate or to further understand the results of this study, we also would discuss the risk. So we are discussing a treatment, and so we would we put our we analyze the results in terms of risk reduction. So when it comes to the surgery only treatment, which is our control, the risk of the control group would turn out to be 52.3%. So 52.3% of this would mean that 52.3% of the patients did not have abdominal recurrence-free survival. So basically, in 52.3% of the patients with the control group, our goal of preventing recurrence or other events, it did not work. So we could see in the treatment group, which is the radiotherapy plus surgery, that 49.6% did not have the abdominal recurrence-free survival. So although it looks like the treatment risk is lower, as already mentioned, it does not seem to be statistically significant. So it may be attributed to other causes. So when it comes to the relative risk is the ratio of the treatment risk compared to the control group risk. And we find that the relative risk in this case is 0.948 or 94.8%. So after treatment, the risk only becomes 94.8% compared to 100% of the control. To further understand this, relative risk reduction is used. So in this case, relative risk reduction is 0.05 or 5%. So after treatment, the relative risk is only reduced by 5% in the treatment group. So if we compare the results of the control group versus the treatment group, there's only a 5% difference or a 5% improvement, basically. And in absolute risk reduction, there are 2.7 or just about 3 less cases of abdominal recurrence or death in every 100 patients that are treated with the treatment group, so the radiotherapy and surgery group, compared to the surgery group alone. So if we have, for every 100 patients that are treated with the radiotherapy plus surgery, there are only about 2.7 or there are only about 3 less cases of abdominal recurrence or death. And using all of these statistics, the number needed to treat is 37. So we could only prevent one case of abdominal recurrence or death for every 37 patients that we treat with the radiotherapy or with the combined management of radiotherapy and surgery. So next slide.
Yeah, so how precise was the treatment effect? So the confidence intervals were reported for all outcomes in the study. So the precision of the treatment effect estimate is indicated by the width of the confidence interval. So in this study, the hazard ratio for abdominal recurrence survival with radiotherapy plus surgery compared to surgery alone was 0.84, with a 95% confidence interval of 0.58 to 1.21, and the first sensitivity analysis in hazard ratio of 0.78 with a 95% confidence interval of 0.53 to 1.60. And the second sensitivity analysis in favor of the radiotherapy plus surgery group. So a narrow confidence interval would suggest a high precision, while a wider would indicate more uncertainty. So in this case, given the confidence interval is relatively wide, spanning from 0.58 to 1.21 and 0.53 to 1.16. This suggests that the estimate is not statistically precise, and the study does not provide strong evidence to definitely conclude a significant treatment effect.
Next, we move on to the applicability of the study to our patients. So we first discussed the biological issues that affect applicability. So as already mentioned previously in our description of the study, uh, the population of the participants in the study, when it comes to the patient, our patient, we find that the sex of the patient, the age of the patient, and the pathology do not affect the applicability. However, we find that potential issues that affect applicability would include comorbidity and race. So for comorbidity, uh, although the way that renal function is measured is different in the study with our patient, we still would have to note that the participants in the study were said to be of normal renal function, but our patient is a patient that has CKD. So this is something to take note of. Maybe we could compute the maybe we could assess our patient in the same terms that the study did when it comes to assessing renal function and also race. So, although it's not explicitly mentioned as a confounding variable, the participants in our study that we found came mostly from research institutions, hospitals, and cancer centers from Europe and North America. So, it is unclear whether the patients are of the same race or not as with our patient, but it seems very less likely that our patient comes from, or rather, most of these participants, there's a big chance that most of the participants in the study were not Asian or were not Filipino. So that's another thing to take note of. There may be differences in the demographic. We're not sure of it, but we do have to look further into that. So anyway, the point here is that these are just some issues that we might have to take note of before we consider giving radiotherapy to our patient. And when it comes to the socio-economic issues of affecting applicability, it's quite similar. We know that Europe and North America, the countries here are quite more well-developed compared to us. And so the availability of radiotherapy might not be as widespread. And this could lead to the availability of our patient or his access to radiotherapy. So in that scenario, if we do plan to give our patient radiotherapy, we have to take an extra step in terms of planning with the patient and planning the logistics of how is the patient going to be able to properly apply or how is he going to be able to receive radiotherapy. It's not as easy as it would be in North America or in Europe. So that's an additional caveat. And our patient's education and the lack of awareness on the disease and his management options may also lead the patient to shy away from the treatment, leading to further difficulties down the road when it comes to applying this sort of treatment to our patient.
Next for individualizing the results. Next slide. So we first answered the question, what is the likely effect of the treatment on your individual patient? So we first estimate the patient's risk for local recurrence with a surgical resection alone. So this value of 0.5 is based on several studies that shows overall local or abdominal recurrence for patients following resection of primary retroperitoneal sarcoma is common at 50% at 5 years after 5 years. So this is the basis for setting the patient's risk for local recurrence with a surgical resection alone. So next, we compute for the relative risk of developing recurrence in those treated with a preoperative radiotherapy in addition to surgical resection. So this is based on the journal being studied po. So this was discussed earlier po by Carl. So to compute for the relative risk, we get the ratio of the uh, treatment risk versus uh, controlled risk. So we calculate for the treatment risk and the controlled risk from the studies. The values given are as follows. So the abdominal recurrence free survival for those receiving surgery only is 61 out of 128 patients. So hence we infer that 67 had a recurrence. So the controlled risk would be 67 out of 128, which is 52.3%. And for those patients receiving preoperative radiotherapy with surgical resection, 60 out of 119 patients experience abdominal recurrence-free survival. Again, we can infer that 59 patients out of 119 experience recurrence. So we get the treatment risk by dividing 59 over 119, we get 49.6%. So we plug in the values and we get an RR of 0.95. Next slide. Then we compute for individual patients' risk for recurrence with preoperative radiotherapy. So we use the estimate of our patient's individual risk for local recurrence with a surgical resection alone and multiply it with the relative risk. So that's 0.95 times 0.5. We get a value of 0.475. And then we compute for the individualized absolute risk reduction. So this is just subtracting the risk for patients for our patient if our patient received surgical resection alone minus the risk of our patient if our patient received surgical resection with preoperative radiotherapy. So that's 0.5 minus 0.475. We get an absolute risk reduction of only 0.025 or 2.5%. And then we compute for the individualized number needed to treat. So that's 1 over absolute risk reduction, which is 1 over 0.025. And we get a value of 40. So we have to treat 40 patients in order to prevent one patient from experiencing recurrence. So in the cases of our patient, since our retroperitoneal sarcoma is a rare disease, so a number needed to treat of 40 patients is a huge number for a rare disease po. So next. So now, would you offer the treatment to your patient? So, in this case, po, based on the journal, so no, we will not be recommending preoperative radiotherapy in addition to surgical resection because of the following reason. First would be the low absolute risk reduction. So it will only reduce the risk of developing recurrence by only 2.5%. And also because of the relatively high number needed to treat of 40 for a rare disease, as I mentioned earlier, and also the additional harm from the radiotherapy due to the possible adverse side effects, and also additional cost to the patient since for in the Philippines, usually one session of radiotherapy would cost patients 3,000 pesos. So it's an additional cost to the patient with additional harm, with very little benefit for our patient po. So we will not be recommending preoperative radiotherapy for our patient. This ends our presentation po for the case discussion and the journal critique.
Okay. Can you turn off the shared screen? Okay. Thank you. Congratulations for the prepared presentation, especially the journal appraisal. I really appreciate your computations of all those numbers. Okay. I hope all journals will have those items inside the journal also, okay? So that we can really understand what's the significance of the research, no? Pero mahirap talagang ilagay lahat ng mga numbers na yon, no? Okay. So, and you can see, if you just look at the journal, you can look back at what I lectured on you on patient management process. No? It inputs the benefit in terms of treatment, benefit, risk, cost, and availability. No? Okay. So I don't think this I don't think this is being discussed frequently in conferences. No, and how to approach it. No, okay. But you can see from the journal now the applicability of this BRCA in the management of your patient. Now, okay. 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 Before I how do we proceed? Let me finish first with the journal critique, just a short one. What are the possible side effects that were mentioned for the radiotherapy? Was there mention of those side effects?
Usually would be nausea, vomiting, enteritis, and more serious effect would be bowel obstruction po.
Bowel
From radiotherapy.
obstruction. Bowel obstruction. Okay. Okay. So I was just thinking, when you treat colorectal cancer, nowadays they give a pre-op radiation also, no? Pre-op radiation. It seems that it's effective, diba? Okay, that's why it's being part of the protocol now. For advanced colorectal cancer, they give pre-op radiation and then followed by chemo and then surgery. No? Okay. So it might not be the same for retroperitoneal sarcoma. No? Okay. Okay. Okay, how do we proceed with the discussion? Okay. In this particular case, you were given all the data already. So it's hard to discuss it using the patient management process in step by step. No? Okay. So what I would suggest, let's discuss it in terms of the time the patient develop the symptoms. Okay. Okay. Example. This patient is a 65-year-old female male presenting with abdominal enlargement at 10 months. Okay, 10 months prior to consults. Okay, so assuming that now is the patient consulted you for the first time at this time, not 10 months. No, okay. So we're not talking about what came after 8 months, 2 months, and then admissions. No, okay. So suppose that the patient comes to you, 65-year-old male, with abdominal enlargement. There was a statement on there were no associated symptoms. Wala, di ba? Can you repeat it? Can you repeat the date today? Yung 10 months? No palpable
10 months prior to admission po, patient. No palpable mass, no abdominal pain, no anorexia, no vomiting, no dysphagia, no melena, no hematochezia.
Okay, so no associated symptoms. Tama? Okay. So if you see this patient at that time, what will be your, just say, considerations muna? Okay. We don't have the PE findings, whatever. No? Okay. Just the chief complaint, chief concern that the problem of abdominal enlargement. So what will you be thinking of? Assuming that even just by telephone consultation, by telemedicine, probably, okay, you have a 65-year-old male presenting with abdominal enlargement without any associated symptoms. So what will you be thinking of? Ano mga possible considerations? Theoretical.
Sir, one of my concerns is ascites po.
Ascites, okay, that's one. Number two,
Possible din po, may bowel obstruction po yung patient.
bowel obstruction, okay. Intestinal obstruction, okay. Ano pa? Meron pa? Ano pa? Wala na? Marami pa yan, di ba? Ano pa?
Of course, sir, the consideration of a tumor growing or a mass.
Okay, tumor, okay. In your patient, tumor lumabas, yung tumor, kasama yon, di ba? Okay, ano pa? Meron pa? Tumor, obstruction, ascites.
In relation then to, sir, apart from a primary tumor, maybe it could also be metastatic. So baka may iba ng, but that might be later on already. Just another thing to consider for me.
Okay, so let's just lump it together as tumor, okay? Tumor, fluid ascites, and intestinal obstruction, and what else? Meron pa ba?
Gastroparesis po.
Gastro,
Paresis po.
paresis is, ano yun? Is gastroparesis. Anong term? What's another term for gastroparesis? Ileus? Is that the same as ileus? Ano? I'm just asking because first time I've heard that gastrointestinal paresis. Is that the same as ileus?
I think, sir, gastroparesis is more on the stomach. If ileus is intestines, gastroparesis is stomach.
Gastro, not
Stomach.
gastrointestinal paresis, gastric paresis. Stomach lang. Kung stomach, gastric lang.
Yes.
Ikaw, Bea, you were the one who brought it up. Saan mo na-encounter? I'm not saying you're wrong, but I'm just trying to learn from you.
Opo, parang paralysis po, sir, ng
Paralysis?
stomach. Hindi nagpapas. Opo.
Hindi siya nag-ano. So, parang paralysis or parang the concept of ileus, hindi gumagalaw. Di ba? Okay.
Yes po.
Ganon? Okay. Paralysis. Okay. What else?
Sir, in relation din po to ascites, since very non-specific po yung abdominal enlargement, maybe we could also consider something like hepatomegaly. Maybe it's the liver that's enlarging.
Hepatomegaly. Okay. Organ
Organ
enlargement. Organ enlargement. Okay. So 5. 1, 2, 3, 4, 5. So probably we can add another one. You can call it non-specific. You don't really know what's the exact etiology because every now and then we also experience abdominal enlargement. What is apparently abdominal enlargement, but it goes away or it comes on and off. No? Okay. Tama? So let's try to introduce the other one. It's non-specific abdominal enlargement. Na? Okay. Which is quite common. Okay. Tama? Among the four or five, that's probably the most common that we experience. I think every now and then you experience that. Parang lumalaki ang tiyan ko, di ba? Okay. After a while, you just observe, nawawala, di ba? Okay. So non-specific, no? Okay. So with those in mind, so what will be okay based on, because you have not yet, we don't have any data on PE. No, okay. So just based on the short history, okay, you have to come out with a tentative diagnosis, parang educated guess, okay? And you have to make an educated guess based on the prevalence, okay? Tama? Prevalence mo na. That's what I'm teaching you. Pattern recognition and prevalence process. Now, since you don't have the sign, we don't have the PE, no, signs, no, mahirap gamitin yung pattern recognition, no? Okay, so you use the prevalence. So what is the most common? Non-specific, di ba? Okay. If you have to make an educated guess, number one is non-specific. Okay. How about number two? ang data mo, 65 years old, male, abdominal enlargement.
Tumor po.
Tumor?
Since elderly.
Okay. So, ano pa? Sino nagsabing tumor? Alisa?
Nika po.
Nika. Okay, okay. Okay, who would venture for other answers?
Sir, I'll try yung fluid po, ascites, since elderly have more comorbidities po, possibly from heart failure or chronic liver disease po.
Okay. Pwede, no? Okay. So, wala tayong data actually, di ba? We don't have the parang formal data gathering on the prevalence of all these different specific diseases, di ba? So we just have to make an educated guess, di ba? So if based on your experience, personal experience at your level, at my level, okay, kung anong nakikita more common, you tend to say, most likely this is tumor, most likely this is ascites, na? Okay, some would even say most likely this is intestinal involvement because meron siyang wala siyang symptoms pa, no? Okay, so it all depends, no? Okay, so you make a tentative make a tentative educated guess. Most likely, sabi ni Nika, tumor, sabi ni Alisa, mga ascites. Okay, so kahit na tentative lang, and then you have to go further than that, no, and evaluate the patient. Okay, so but before you settle for the non-specific one, you have to give the benefit of the doubt that the patient might have a specific pathology there, no, before you settle for the non-specific. Okay, okay. So what will tell you that you're dealing with a tumor, Nika? If you now have a chance to examine the patient, na? Okay. Anong hahanapin mo?
So first po, based po sa history mo, siguro probe more on other constitutional signs and symptoms such as weight loss, early satiety po, which would point more po to malignancy po. And then for history, sir, yun po.
Okay. So yung sinasabi na you were considering possible tumors, okay, as number one, no? So what you will do right away is to examine the abdomen. Tama? Kapain mo na kagad, di ba? Okay. So if you are able to palpate a tumor, that's it. Okay? But if you're not able to palpate a mass there, you cannot entirely rule out walang mass pa rin, di ba? But you have to go down to the others, no? To the other considerations, no? Pero kung may nakapakang tumor, that's it, no? Parang nag-zero in ka na, no? Okay? So sabihin natin, walang tumor. So what will be the findings on physical examination? Remember, at this time you're now doing the physical exam, no? Okay. What will be the findings that will tell you that you're dealing with ascites, intestinal obstruction, organ enlargement? Elisa, what will tell you that you're dealing with ascites?
Sir,
On
for
PE.
ascites po,
On PE, ha?
you can perform the maneuver, yung fluid wave test po,
Okay.
and the shifting dullness test.
Okay, kung may fluid, if you're convinced that it's really fluid, no, then you're dealing with ascites, no? Okay, we'll get back to that, ha? Kasi we have to extend it further to say what's the cause of the ascites, di ba? Okay. And then, okay, what will tell you that you're dealing with intestinal obstruction? Carwin, ikaw nagsabi obstruction. PE. Unmute ka, okay. What P findings suggest intestinal obstruction?
For ano po, for auscultation po sa abdomen, ang pwede pong first hypoactive yung bowel sounds po, and then magiging hyperactive rin po. And then more of I'm thinking rin po sa history.
Yung PE mo na, PE mo na, PE mo na, PE mo
Yung sa
na.
auscultation po.
Okay. So, auscultation.
Yes.
Any other signs that you will utilize? You will look for to convince you that you're dealing with intestinal obstruction?
Pwede rin po, on palpation rin po, pwedeng maka-experience si patient ng tenderness and yun po.
Okay. Ano pa? Meron pa? Okay. The others can contribute. Abdominal pain when the intestine is contracting. Okay. Ano pa? Enlargement, of course, andyan yan. Okay. Ano pa? What are the cardinal signs of obstructions?
Sir, the cardinal signs are pain, vomiting, obstipation, and distension, both, sir.
Okay. So ito, hanapin mo yung PE sa PE. So irerectal ninyo. Okay. So you can do a rectal exam. If the rectal vault is collapsed, no, that could be a sign that you're dealing with obstruction. Di ba? Okay. So, irerectal ninyo, di ba? Okay. Kasi yung on and off na high auscultation, you can use that pero very non-specific siya, di ba? Ang hirap i-monitor, di ba? But if you do a rectal exam, then if the rectal vault is collapsed, most likely you might be dealing with obstruction or you might be able to find a mass there, di ba? Okay. Okay. So utilize the PE to check, to rule out, to zero in on the possible cause of the abdominal enlargement. Nah? Okay. So the organ enlargement, like hepatomegaly, no? So, Jose, anong gagawin mo on PE? Palpate.
For the PE, sir, yes, palpate on the right upper quadrant.
Okay.
And attempt to measure by finger breaths. Well, that's a rough estimate, but that's what you were told that if you could still palpate the liver edge, if it's more than if I believe 2 fingerprints or 3 under the subcostal margin.
Okay.
Then that's
Okay. So going back, when you have a patient like this, 65-year-old male presenting with abdominal enlargement, initially wala pa siyang yung mga well-established na signs and associated symptoms, no? Okay. So usually very few yung mga symptoms that will give you a clue, no? So you think of those 5 and then do your physical examination, no? So if you find something that will indicate a tumor, that's it. You zero in right away on this tumor, no? Okay. And then if you see a fluid, ascites ka na, di ba? If you see a rectal vault na collapse, intestinal obstruction, no? If you feel a enlarged liver, no? That's it, no? Hepatomegaly, di ba? Kung wala ito lahat, so what will you do? Baka non-specific siya, no? But you have to consider the how long has this been present, no? Okay. So you go back to the history. If this has been present for 5 years and then it's not progressive, no, on and off, no? Okay. A lot of patients will complain of this abdominal enlargement, pero usually 5 years na ito, 3 years na ito, pero it's not progressing, but it's bothering them, no? Okay. So you can say that most likely wala, no? Okay. So what will be, you can either advise the patients, it's either to observe further or to do examinations already, no? Okay. So it all depends on what you are suspecting, and also it all depends on the psychological makeup of your patient. If he's very anxious that to know what's the answer, you may have to do, just give them the options. It's either you observe or you do diagnostic tests, okay? So if he's very anxious, you may have to do diagnostic tests already, no? Okay, okay. Okay, at this point, wala tayong other findings, di ba? Okay, okay. But if you find something, you zero in on that findings already, no? Okay. So if you were to do a diagnostic test at this time, what would you order? Walang findings on PE, ha? Walang findings on PE. Basta pwedeng non-specific din siya, di ba? Okay. So anong test ang gagawin niyo kung talagang gusto ng pasyente na I want to know what's causing this problem? We're talking about the screening test, di ba? Kasi wala tayong makita, di ba? So anong screening test that you can use for abdominal enlargement? Options 1.
Sir, maybe we could request for an abdominal X-ray. X-ray from PA and lateral views.
Okay, X-ray, 1 option. Sige. Number 2 option.
Ultrasound po.
Ultrasound, Alisa, okay. Sino nagsumagot ng ultrasound? Si Bea o si Luto?
Ako po, sir.
Okay, Bea, okay. Ano pa? Meron pa? Options lang naman ito, then we will dissect. The approach is really to list down the options first. No? Kasi para to make you make a decision. Kasi the practice of majority of our physicians in the country, kung anong nakasanayan nila, isi-CT scan nila kagad, di ba? Tama? May iba, MRI. So popular MRI ngayon, MRI na kagad, di ba? Okay. So list down the options first. X-ray, CT, ultrasound, and the plus. CT scan is another option. MRI is another option, di ba? Okay. So then try to see the benefit, risk, cost, availability. No? Okay. And then also consider the options of the parang you can say preliminary lang naman. The concept of parang screening lang muna. No? Okay. Example, you can do the ultrasound first. Kung may makita, then if you need your CT scan, then you do it. No? Okay. So you can start with the yung option na parang in the concept of preliminary screening, di ba? Okay. So, but again, it will boil down to most likely what does the patient has? Is that a obstruction or tumor or ano? You just have to make some educated guess. Probable lang, ha? Okay. So if you think that there's an obstruction there, you might opt to, parang preliminary concept is that you do the x-ray first. Di ba? Plain abdomen, upright and supine. Di ba? Kung may mga dilatation o wala, no? Nor magkano lang yung x-ray. And it can tell you that sometimes it can reveal the intestinal obstruction already, di ba? Okay. Then after that, kung may suspect ka ng iba, then you can do your CT scan after the x-ray. Baka pag may nakita kang tumor or ano, no, an abnormal finding, you can proceed to your CT scan. No? Okay. Now, if you're thinking, kasing x-ray, halos wala nang gumagawa noon, di ba? Nowadays. So, they go for ultrasound to screen every organ of the body, of the abdomen. Di ba? The kidney. What can the ultrasound, what organs are easily seen by the ultrasound, investigated by the ultrasound? Kidney,
Kidneys, the
Hepatobiliary
liver,
tract, liver, kidney.
ano pa? Intestine kaya? Hindi, mahina sa intestine, di ba? Okay, ano pa?
the gallbladder,
Gallbladder.
biliary tract.
Okay. Okay. So you can opt for ultrasound first if you are considering parang screening kasi ito, you're doing it on the basis of screening. So you do the ultrasound first. If you find something, then kung normal lahat, no, you can tell the patient, you can just observe further, no? Okay. Kung may nakitang tumor somewhere there, no, inside, then you can go further. No, you can do CT scan or MRI. Okay. Okay. So that's the approach, no? Okay. Now, 8 months after he came back, okay? Sabihin natin, observe mo lang, no? Okay. At 8 months after he came back, now, ano yung mga symptoms ng 8 months? Wag mo isama mo na yung CT scan, ha? 8 months after. Meron siyang LBM, loose bowel movement.
Loose stools, early satiety, and with bipedal edema po.
Bipedal edema, early satiety, and loose bowel movement. Na? Yun lang? Okay. Okay, wala tayong data on the PE. Tama? Wala tayong data on the PE. No? So if you have this data, sabi natin wala pang PE. Okay? Anong iisipin niyo ngayon at this point in time, 8 months after, meron siyang symptoms. Dati-dati wala, di ba? Anong iisipin ninyo? GI? Ano pinaka-significant dito? Among the 3 that additional symptoms that he had, new development of symptoms among the 3, early satiety, ano pa, loose bowel movement, and then bipedal edema. Okay. Among the 3, saan ka magpo-focus? Although you consider mo 3, di ba? But where do you focus? Ano pinaka-significant? Okay. Madeline?
I think the abdominal enlargement pa rin po, sir.
Okay, may abdominal enlargement siya. No, wala pa tayo nakakapa. Hindi pa natin, we're not doing the PE yet, no? Kasi wala tayong data, di ba? So she has abdominal enlargement 10 months ago. At that time, wala siya, no associated symptoms, no? So, but we must have some considerations, no? But now, pina-observe natin, then 8 months, 2 months after, he now has early satiety on top of the abdominal enlargement, no? Loose bowel movement, and then bipedal edema. So saan ka magfo-focus to come out with a diagnosis?
I think the hard to say po, sir, pero I think I would focus on the loose bowel movement, because I think you can more or less rule out a possible, because if we were thinking of a gut obstruction, you would less likely see flatus or bowel movement. But since the patient is presenting with loose stools, you could sort of rule out a possible CGO or a PGO po for this patient.
Okay, that's your opinion. Okay, how about the others?
For me, sir, I would look at the bipedal edema. Because for me, honestly, I first would think of how in pregnancy, a lot of pregnant patients would have bipedal edema also, and that would be because of the growing fetus causing an impingement of some sort on the veins. And siguro if one of our considerations is an abdominal mass or a tumor, then it's possible that that's one of the mechanisms also that would cause the bipedal edema. Of course, it's not the only thing we should consider, but for me po parang that's it would shoot up in terms of priority.
Okay, so among the three, you would give most importance to the bipedal edema and then start thinking about diagnosis already. Now, that is related to the abdominal enlargement. Okay, so any other opinion? Medyo specific yung bipedal edema na, di ba? Okay, compared to the LBM, no? And the early satiety, no? Okay. Tama? Okay. I'm not saying you should not focus on the LBM and early satiety, but just a prioritization, no? Okay. So now that you saw a bipedal edema, anong isipin na natin? Ascites. Baka may ascites siya related to the abdominal enlargement causing ascites, and also with ascites you can also have early satiety, feeling of early satiety, and also yung LBM could be non-specific, di ba? Okay. Okay. So let's assume that we're now focusing on the LBM or the bipedal edema. Okay. So anong diagnostic test that you will do? Sabihin natin yung PE mo at this time, wala ka pa rin nakakapa. Ha? Wala kang nakakapang mass. No? Or you don't have any data on the PE. Sabihin natin ganun na lang. No? Okay. I hope you're appreciating what I'm trying to do. I'm trying to tailor in yung talagang real life situation, no, when you see a patient, no. Kasi sa ngayon kasi you got all the data on the night. Sunod-sunod na di ba? Okay. But you can see this, you can encounter this patient at 10 months, at 8 months, and then the question is, what will you do? What will you be thinking of? No? Okay. So anong gagawin niyo kung walang PE findings, walang abdominal enlargement, early satiety, loose bowel movement, and then bipedal edema? So will you still do abdominal X-ray? Will you do ultrasound? Will you do CT scan? Anybody? Nika?
Sir, since we're only considering for the bipedal edema po, so since most likely it's ascites.
Ascites. Okay. Okay. And then,
maybe we can go po for the ultrasound po.
okay. So option 1 is ultrasound. Hindi na muna yung plain abdomen X-ray.
Yes, because it's less likely spectrum.
Number 2 could be CT scan. Options muna, okay?
Yes.
Okay. So between the two, which one will you go first?
Ultrasound po.
Ultrasound to screen muna, di ba? Okay. Okay, to screen because your objective is to screen, you still baka ascites lang kalaban mo rin, di ba? And then you want to know kung merong findings like abdominal tumor that you are missing there, okay? So you can do ultrasound first, no? Okay. So, and then in terms of cost, mas mura, di ba? Okay. Availability, it's always available, okay? So you can see in the case presented here, CT scan kaagad, no? Tama? Walang ultrasound, okay? So in your practice, you can try out ultrasound muna, okay? So looking at the data that you presented at 8 months, yung ginawa nilang CT scan, meron na nakitang bukol. Di ba? How big is the bukol at that time? 8 months.
Sir, sorry po. Initially po nag-ultrasound muna.
Nag-ultrasound siya
Tapos
muna?
parang hindi on ultrasound po, non-visualized na po yung right kidney. So parang nagsuspect na po ng mass at this point. Kaya nag-order na po ata ng CT scan.
Okay. I didn't get it. Yung presentation niyo may ultrasound na? Was it part of your presentation? Or hidden data?
Yes po.
It was part of the presentation.
It was part po.
So ultrasound was done first. Okay. So anong nakita sa ultrasound? Sige. Again. Tama yung approach, no? Do the ultrasound first to screen. So what was found? Non-visualizing right kidney. Mass. May nakitang mass na?
Yes, opo.
How big was the mass?
Wala po.
Wala. No mention?
Yung no mention po, sir. Yung impression po ng ultrasound was normal liver, gallbladder, spleen, pancreas, non-dilated biliary tree, non-visualized right kidney, CT scan correlation suggested. Yun lang po.
Sige.
No mention po of mass na nakita.
Okay, walang mention of mass, non-visualizing. Anong description sa kidney?
Sorry, sir. Yung right kidney not visualized, yun lang po yung nakalagay sa description.
Okay. So one thing that you have to learn also, how to interpret the results given to you. Okay? So, kasi pag nag-ultrasound tayo, makikita natin yung kidney. Di ba? In terms of structure, based on the imaging, is it big in size? Is there small in size? And also if there are tumors there. No? Okay. So, hindi naman natin dinidetermine ang function ng kidney based on the ultrasound. No? It's based on the structure. So, non-visualized kidneys. Bakit? So you have to ask yourself, bakit hindi na-visualize yung kidney? Diba? But there's a density there. No? Tama? There's a density there, so which could be a mass already based on your interpretation. No? Okay. So the lesson there, you must know how to interpret also. Don't just rely all the way yung mga radiologist report. No? You have to correlate it with your clinical findings. No? Make your own interpretation. Kasi yung mga reports ng mga ultrasonographers, no, they differ in terms of expertise, in terms of experience, in terms of clarity of readings, no? Okay. So, pag sinabing non-visualizing kidney, so you start thinking, bakit non-visualizing kidney? Baka may mass na siya doon. Okay. Okay. So, kung may definite findings that kidney is normal in size, there's an adjacent mass, no? That's a different story, di ba? So you will be thinking of a retroperitoneal mass already, no? So So the results of the ultrasound was not very definite. So you need, kasi may findings now in that area, walang ascites, ha? So you were thinking of ascites, walang ascites, walang hepatomegaly on ultrasound, wala. Okay. Most likely walang intestinal obstruction, di ba? Okay. So you now focus on that density on the right side. Okay. So you're not, yung impression mo could be there's a mass there on the right, beside the right kidney, or the kidney itself, baka there's a mass there. No? Okay. So you want to be more definite about what it is because you're not sure. So you need another paraclinical diagnostic procedure, right? Okay. So what will be the next paraclinical diagnostic procedure that you will do? Pinag-usapan natin kanina, CT scan, MRI. So which one will you choose? CT scan, MRI. So how do you compare the two in terms of benefit? Benefit is, your goal is to be more definite about your findings, that there is something there in the kidney, in the kidney area. No? So anong difference between MRI and CT scan? Higher resolution for MRI, lower resolution for CT scan. Are you aware of the differences? Sige nga. Jose, are you aware? Kumanon ka eh.
Yes, sir. Opo.
Ano?
For CT scan, it's more of it takes a lot of
Nag-
a lot of continuous. Yes po, sorry. Yung CT scan po para siyang continuously taking a fast series of parang X-rays po, while MRI uses radio waves, I think. And with CT scan, it is a different type of image. MRI po would be higher resolution, but MRI is, I think it's more indicated with, or sa soft tissues ba? Or,
Sige, contribute. Can others contribute? So what's the difference between the two? So you must know the difference, the pros and cons of the two for you to make a decision, aside from the cost later on. Diba? Okay. You consider first the benefit and the risk. Okay. So in terms of risk, ang priority is the benefit, diba? Pero yung risk, just to mention, yung MRI, you use what? Magnet, mga ano, diba? Okay. To create some image. Yung sa CT scan, you use radiation, diba? So basically, that's the difference. In both, they can use contrast. That could be another risk, di ba? Contrast study, di ba? Okay. But in terms of resolutions, when I say resolutions and how they can, how accurately they can image the findings, which one is better? No? You mentioned about soft tissue, di ba? Carlos, di ba? So mas maganda yung MRI sa soft tissue. Anybody?
Generally, MRIs are better at visualizing soft tissue. With the CT scan, it's good at assessing sort of more bony structures. And then usually hindi po first line yung MRI po as a diagnostic. Usually inuna po yung CT to assess the bony structures. Tapos a further visualization would be required but to look at the soft tissue structures. MRI may be done second.
Okay. So, hindi first line ng MRI. Bakit hindi first line ng MRI? Because baka kaya na ng CT scan. Tama? Pwede yan. CT scan might be as good as MRI in that area.
I think also din po, logistically, mas matagal po mag-MRI.
Okay. Or the cost, di ba? Okay. So, since kung pareho lang yung information that you can get from your CT scan versus MRI, you use and then the cost is, there's a marked difference between the cost, then you can use CT scan already. Di ba? Okay. So in this particular patient, nagawa yung CT scan, no? Ganon, no? So that's how you choose, no? CT scan versus MRI. You can try CT scan, no? Ngayon, kasi a lot of physicians, they're so used to popularity of MRI and also because they want to, so this is part of our learning also in real life, no? There are some hospitals who are promoting their MRI. So they said, mag-MRI na lang kayo, lahat MRI ninyo, okay? Okay? Rather than doing the CT scan, which is cheaper, no? Ganon than the MRI, no? Okay? So may mga commercialization of medicine dyan sa ating practice in the Philippines as well as abroad, no? Okay? So CT scan, the next is CT scan, no? So CT scan was done, it showed ano yung findings?
It showed po 26.8 by 23.5 by 23.9 cm po na mass with central necrotic solid component and fatty component. So the
Okay.
impression,
Located where? Adjacent to the kidney? Na-visualize yung kidney, no?
arising from the right posterior pararenal space po, infiltrating and anteromedially displacing the right kidney po, and the proximal right collecting, urinary collecting system po.
So with the CT scan, the kidney was visualized already. It's intact. It's separate. Now there's a mass there adjacent to that. Nah, okay. So that's why the impression could be a retroperitoneal mass. Okay. So if the mass has some attachment to the kidney, you might consider as part of your differential, it could be a kidney tumor. Now, but if the report says that it just displaces the kidney to one side, so you're dealing, and the main mass is outside the kidney, then you're dealing with a retroperitoneal mass. Okay? So with that, your diagnosis now will be, after the CT scan, retroperitoneal tumor, right side. No? Okay? So question now is this definite na yun, di ba? Meron ka ng definite findings ngayon, no? Okay. So does this explain all the things that the patient is experiencing? Abdominal enlargement, no? Yung size of the tumor, 28 something, no? Okay. And then the ascites, can it explain the ascites, the pedal edema? Can it explain by bilateral? You can explain it because baka involved na kidney, di ba? Okay. And then, does it explain the early satiety? Yes, no? Kasi may mass doon. How about the loose bowel movement? How do you explain that? Pwede rin ba? Loose bowel movement associated with the right peritoneal mass, retroperitoneal mass. Hanapin niyo yung mga connection kung meron, no? Kung wala, baka sabihin mo, baka non-specific lang siya, no? Okay. Then you try to investigate. Ang LBM mo ba is talagang loose, watery, ganun, or malambot lang, okay? So, kuminsan, it's a matter of using the words, di ba? Okay, so you have to ask further, ano ba talaga yung sinasabi mong diarrhea, ano yung sinasabi mong loose bowel movement, no? Ganon, no? So investigate further. But for the moment, we put that aside. Baka it could be a secondary effect of the tumor on the intestine, no? Whatever, no? Okay. So kasi kung may tumor doon, we expect some obstruction, di ba? Okay. Usually not LBM, but it's still possible, no? Okay. So with that findings on CT scan, ang primary diagnosis mo right away is retroperitoneal tumor. The next question is that benign or malignant? Okay. So at this point, nakikita niyo yung flow ng aking patient management process. Okay. So at this point, is it malignant or benign? So which one will you choose? Your definite based on CT scan, it's a retroperitoneal tumor, okay, beside the right kidney. affecting the right kidney. Meron bang naka-mention sa ureter? Is it obstructing the ureter?
Yes po. The proximal ureter po is
Dilated.
yes po.
Dilated. So may mga effects on the on the ureter, no? Okay. So the next question is to decide, is it malignant? Is it benign? So anong pipiliin niyo?
Parang based po sir on prevalence. Usually most common po na for retroperitoneal tumors, parang mas common po na malignant kaysa sa benign.
Okay. Gamitin natin muna yung pattern recognition, na? Okay, before the prevalence, na? Okay, yan ang tinuturo ko, no? Is there any pattern, any signs and symptoms that will indicate that the mass is benign or the mass is malignant? Na? So ang magre-rely ka na ngayon is based on the CT scan findings, na? Although pwede niyo gamitin yung piece, assuming yung pictures na pinakita niyo sa akin kanina, okay? Assuming that's the picture that 8 months ago. So, meron siyang malaking mass sa right side, di ba? Okay. So, nakapanin niyo, okay? And then CT scan, yun ang findings. Okay, so what will be the signs that will indicate that that mass, that retroperitoneal mass is benign, and what will indicate that it's malignant? Ano yung mga pattern? Calvin? Anybody? Bea?
Yung speed po ng growth po ng mass.
Ano?
Yung speed po ng or rate po ng growth po ng mass.
Okay, you can use that, but before you use that, you use the sign muna. Okay, priority is still the sign. Sign means based on your PE findings, and then you have CT scan findings, that's more reliable, di ba? Okay. Saka na lang yung history ng
po,
growth. Okay.
Pwede po yung hard fixed
Okay.
na characteristic ng mass.
Okay. So you palpate. When you palpate, there's a mass which is hard, and then it's fixed.
Fixed
Okay.
po.
So you start thinking of malignancy. Okay. If it's soft and it's movable, you think of benign one. Okay. So yan ang tinatawag na sign-based pattern recognition. Okay. So, and then based on the CT scan, kinapa ninyo? Anong findings niyo sa kapanin niyo?
Yes, sir. So above po the level of the umbilicus, the whole upper half of that abdomen, medyo mas firm po siya. Firm po siya. And then below the umbilicus, parang soft. Distended pa rin po, pero softer compared to the upper half of the abdomen.
And then yung mobility.
Mobility, sir, it's when we were trying to mobilize it, parang it wasn't fixed naman po, sir, but it also wasn't very mobile. But it wasn't fixed. If anything that we palpated, it did not seem fixed po.
So if we have findings on the spectrum of the two extremes, one is talagang readily magalaw, no? So most likely it's benign, di ba? Yung talagang natataas nyo, napapalitan yung pwesto, no? And then on the other end is talagang dikit na dikit, hindi nyo nagagalaw, no? So in which case you say it's malignant, di ba? Ito naman, in one case yung gumagalaw, you say most likely it's benign, di ba? Okay? Just based on PE, di ba? Okay? And then you look at the CT scan. Ano yung CT scan? The mass, if it's well delineated, the border, no, that could be a sign that it's benign. Okay? The other clue that it's benign could be baka complex. May mga fluid, may mga solid. No? Okay? So you use these parameters. Ang number one important parameter is the border. No? So we know that cancer usually have ill-defined border because it tends to invade the surrounding tissue. Diba? Okay, kaya ill-defined ang border. But if it's well-defined, most likely it's benign. That's a clue that could be a clue indicative of benign. Complex, usually fluid, may fluid siya, may solid element, no? Okay, usually pag cancer, usually uniformly solid, no? But there are exceptions, no? Okay? Okay? Pero kung purely fluid siya, benign siya. Di ba? Pag complex, kung majority are solid, konti lang fluid, you might consider malignancy already. Okay? Okay. So this is the algorithm for all types of tumor, no? But for retroperitoneal, yung mga sarcomas, retroperitoneal, it's the size. Okay? It's the size and then the rapidity of growth, sabi ni Bea, okay? Okay. Kung in 1 year's time, ganun nakalaki, na most likely malignant na yun, no? And then the size, no? How big is the size? 28 centimeters.
26.8.
6 centimeters. Usually mga pag ganung size, malaki na. I don't have the cut-off, but usually I use the size also to consider sarcoma. No? Sarcoma can occur in the outside the abdomen. Let's say sarcoma of the extremities, di ba? Ganon. If the size is malaki na, and then it has been there for recently, then you think of sarcoma rather than a benign lipoma or ano. Okay? So yung size is another factor to consider. Okay? Yung sa kanya malaki, so you consider sarcoma, but you cannot rule out benign pa rin, na? Okay? So your primary diagnosis now will be retroperitoneal tumor, most likely sarcoma, because of the CT scan findings, and also your based mainly on the CT scan finding, because your PE is not very di pa masyadong reliable kasi gumagalaw, di ba? Okay, yung size lang, na? So yung secondary diagnosis mo could be benign, na? So that's how you put your primary and secondary diagnosis. Okay, so you don't put in, wag na ilagay yung colorectal lymphoma and then the renal neoplasm unless you're considering kidney tumor yon, no? Kasi but based on the CT scan, dinisplace lang niya, di ba? Okay, so the kidney was just displaced by the retroperitoneal tumor. Okay, so when you put down your primary and secondary, you focus on the tumor, whether it's benign or malignant. No? Okay, so that's how you use the processes, no? Okay, how to do the differentials, no? 1 and 2. 1 and 2 lang, ha? Huwag na yung dagdagang ang daming, pag dinagdag yung marami, maguguluhan lang kayo, no? Okay, so number 1 is sarcoma, number 2, benign. Okay, now how reliable is the liposarcoma? It was given by the CT scan. Tama? Hindi galing sa atin yan, hindi galing sa clinicians, di ba? Okay. So again, they base it on pattern. Maraming taba, maraming fat tissue. Okay? But if you have to make a primary diagnosis, retroperitoneal sarcoma, most likely liposarcoma, your secondary diagnosis could be retroperitoneal sarcoma, could be other types of sarcoma. So there are so many different types of sarcoma. You can have fibrosarcoma, hemangiosarcoma, no? Ganon. Okay? So, but since there's a finding there that it's full of fat, kaya the radiologist consider liposarcoma. So remember, take note that he uses the word most likely. Diba? Okay? So it's possible it could be something else. Okay? Okay? So after that, so you now have your pre-treatment diagnosis. You start treating now. So you start with your diagnosis at this point in time. No? So 8 months pa lang, nakita na niyo, dapat may diagnosis na yun, then you start treating already. Ewan ko kung bakit umabot pa ng 8 months after, di ba? So at that time, there must be a decision already, di ba? Okay. So when deciding on the treatment diagnosis, you start off with your overall diagnosis pre-treatment. So you have a retroperitoneal sarcoma, most likely, and impinging on the kidney, involving on the kidney and also the ureter, okay, causing some kidney problem. Yung kidney problem niya is part of the tumor problem, di ba? It was not there before. Wala siyang pre-existing chronic kidney problem, di ba? Okay. So the target there is to resolve that kidney tumor, that retroperitoneal sarcoma tumor to solve the kidney problem, di ba? Okay. So yan ang target natin, di ba? Okay. Okay. Ano ba bang sasabihin ko? I forgot something. 8 months ago. Any questions so far? I'm trying to recall. Any questions? No questions so far? Okay. Ano yung wisdom of doing a biopsy? Na biopsy siya, di ba? After the CT scan, meron ka ng tumor. Okay? Sarcoma versus a small chance it's benign. Okay? So do you need to do a biopsy? Or pwedeng hindi na, diretso na. That's another option, di ba? So, can you justify the biopsy? Can somebody justify doing a biopsy?
For me personally po, considering the diagnostic imaging findings po, I think a biopsy may be unnecessary po kasi the features po on the CT scan are more indicative na po of liposarcoma. But I tried to look it up po sa significance of the biopsy po, and I saw po na it's significant po in differentiating the type. So if it's well differentiated or the differentiated liposarcoma, as it would differ po in terms of management. In cases po of the latter one, the differentiated liposarcoma, it would need a neoadjuvant chemoradiotherapy po. Then unlike the well differentiated, wherein you can proceed lang po with the surgical excision of the tumor po. Since the differentiated po is highly aggressive and more prone to metastasis po.
Okay. So you go back to my patient management process, indications for doing something, okay? Number one, based on your primary and secondary, how certain are you with your primary, okay? Kung quite certain, you don't need to do a diagnostic procedure. Number two, process that you use, even if you have secondary diagnosis, if the treatment will be the same, no, you don't have to do the biopsy anymore, okay? So you have to justify doing a biopsy. One justification is that you might consider baka kaya pa ng chemotherapy ito, palitin natin, no? You want to know the specific type of sarcoma, no? Okay? Okay. So that's why they use a core needle, kasi kung needle biopsy lang, mahirap i-differentiate in different types of sarcoma. They use a core needle to differentiate whether it's liposarcoma or ano, no? Okay. Liposarcoma, usually baka it carries a better prognosis compared to yung mga fibrosarcoma or other types of sarcoma. Okay, i-justify lang yon, na? But if the treatment is the same, you have to do surgery, whatever it is, whether liposarcoma, fibrosarcoma, hemangiosarcoma, okay, then you don't need to do the biopsy anymore. Okay, useless. Okay, okay, get it? How to use the process that I'm teaching you. Okay, so now after that, with what's your goal of treatment? Your goal of treatment will be to resolve. Ang nakalagay niyo sa inyo, to remove. No? Don't be biased with, with surgery muna. Okay? So treatment is to resolve, you can say eradicate, wala namang connotation na surgery, di ba? Okay? And then, after that, you put down the options. Options will be surgery alone, or initially surgery followed by radiotherapy or chemotherapy, okay? Or another option is chemotherapy first, okay? Or radiotherapy first, okay? So think of the maraming options yan available in the literature, no? Okay? So there's no one absolute way of doing things, no? Okay, and then don't rely too much on popularity. You have to dissect, you have to compare, no? In terms of benefit, risk, cost, availability, no? Okay, so in terms, you have read the journal, yung pre-op radiotherapy does not offer significant difference, no? So baka uunahin na lang yung surgery, di ba? Have you read on the chemotherapy? Wala. Wala. Okay, so just keep that options open. Kung minsan, they do chemotherapy first, and then radiotherapy, surgery. Diba? But okay, but I'm just being open-minded, but based on my experience, usually chemotherapy will be done after, no? Because what you're after will be yung distant recurrence, distant metastasis after a sarcoma. Okay, the sarcoma usually spread to the lungs, no, and the most common site, no. That's why usually the protocol that I'm used to will be surgery first, followed by chemotherapy, no. Okay, okay. But of course, there are other options coming out now. You do the pre-op radiotherapy followed by surgery, or surgery first, then post-op radiotherapy, and then chemotherapy. Ganun. Maraming options, no? Okay? Now, in terms of risk, you just consider the risk of radiation, the risk of chemotherapy, the risk of surgery. Okay? If the mass cannot be removed safely, in case there's an evaluation there, then you don't give that as the first option. You might try out radiotherapy or chemotherapy first. So it all depends. Okay? So walang fixed na protocol dyan, ha? You have to depend on the various situations and circumstances. Okay? So sabihin natin, based on CT scan, the CT scan can best delineate the extent of the tumor. No? Naka-impinge lang naman, di ba? Tinutulak lang naman. No? Okay? So walang involvement of the big vessels, yung mga aorta, walang involvement, no? Walang nakalagay, di ba? Okay. So pwedeng i-surgery muna, no? Then after that, you look at the histopath, whether it's liposarcoma talaga or other types of sarcoma, and then make a decision whether to give radiotherapy. Indications for radiotherapy, probably one of them will be hindi nyo natanggal, hindi R0, di ba? R1, R2, no? Baka may naiwan, no? Okay? So, no complete resection, then you may have to do radiotherapy after, no? Okay? Then, kung natanggal lahat, no? Then you consider giving chemotherapy, no? After, no? Okay? So all of this will be dependent on the benefit, risk, and also the patient situation, and also the cost availability. No? Okay? Dito siya sa government hospital, okay na yan, wala nang cost ang pinag-uusapan. Di ba? Okay? Pero kung nasa private hospital setting, you have to consider the cost talaga. No? Okay? Mahal yan. No? And then availability, where is this patient from? Manila. Kung nasa Sampaloc, kung nasa bundok siya, no, talagang wala nang radiotherapy dyan, wala nang chemo, di ba? Okay. So you have to do surgery right away, di ba? Okay. So you can see how this patient management process will go, no? Okay. Then before the surgery, you prepare the patients for the operation, no? Okay. So you kung may mataas yung BUN creatinine niya, no? may azotemia siya, kung mataas, then you have to control that, di ba, before the operation. No? Okay. Any other problem that she has?
Dok, may malnutri, parang cachectic din po yung
Okay,
patient.
hectic.
So,
So you might have to build up the patient's nutrition also before surgery. Okay? Okay, ano pa? So ganun yung process, ha? You go direct to the diagnosis and then you do other things, no? Kung kailangan, kung needed to contribute to the treatment, no? Okay? Okay. So hindi yung gagawin mo ng lahat, no? Todo, tapos hindi mo rin magagamit, di ba? So sayang lang, no? Okay, focus talaga, no? Okay. Okay. So I think that's about it. Then after that, of course, maganda yung explanation nyo on health promotions, no? At this point, you tell the patients already, they usually ask you, Doc, what's the cause of this tumor? Diba? You have to explain, no? Okay. And then you can tell them what's the prognosis, and then you can also tell them, but do it in a ano, acceptable way na hindi siya matatakot, no? Okay. And then tell them after the operation what should be done, no? Okay. You should be monitoring, etc., etc. No? Okay. Okay. Yung prostate pala, how significant is the prostate? Paano yun na-estimate yung 40 grams? Were you taught how to estimate the 40 grams?
Yes, sir. Using yung finger breaths po. On DRE. Parang when you're inside the rectum, you try to cover you can feel, especially with the patients with the enlarged prostates, you could sort of feel where the borders of the prostate are, and then try to cover all of the surface that you could feel with a finger breath. And then per finger breath po, it's around, I think, 10 grams. So for the patient, I was able to feel po mga 40 grams po yung sa estimate ko po.
Okay. So I still question that. How reliable is that? No. Okay.
Yes po, sir. Especially given the differences in finger sizes.
Yeah, the size na lang. The size na lang. Translate in terms of grams, mahirap, no? Anyway, that's a protocol. And then yung mga frequency of urination. Kumisan you can have prostatic hypertrophy but it's not causing those frequency of urination, di ba? Meron mga tinatawag na non-specific na frequency of urination. Basta umiihi siya, okay lang, di ba? Okay. So just focus on the retroperitoneal sarcoma and also in preparation for surgery, okay, try to build up the patient's nutrition and also the kidney function, no? Okay. Okay. So, okay, I think that's about it before we adjourn. Any questions? Ano pa? Bea, anything? Anything to add?
Parang wala na po, sir.
Wala na. Okay. Madeline.
None naman po, sir.
Chua, Carwin.
none naman po, sir.
Wala. Okay, Nika.
No questions naman.
No questions. How about your feedback?
Very high yield discussions.
So you're interns already, di ba? Interns na kayo. So I'm trying to teach you yung direct patient management. No? Okay. So cost efficient. No? Okay. Okay. Alisa, anything?
No questions po, sir, but I appreciated the case kasi it's my first time po seeing a case of retroperitoneal sarcoma or tumor po in general.
Yeah. Okay. It's not common, retroperitoneal sarcoma, no? Okay, but you know the approach now, no? So, maraming na-wasted moves eh, di ba? Kung ano. Okay. Okay, how about you? The coordinator, Jose Carlos, anything?
Yes, sir. For me, sir, I have no more questions, sir, but I also appreciate that being able to review how we should think with regards to the patient management process and how helpful the patient management process is.
Okay. Okay, what's your question? You had-
Sorry, sir.
you
No more
had a
questions.
question. No more questions. Okay. So if there are no more questions, okay, let's call it a day. Let's have a group picture taking first, no? Before we reach 1 p.m. Okay, so who wants to take the picture? Okay, get ready. 1, 2. Okay. Okay, so okay, all of you answered the OLETE already. All of you. Online learning curve evaluation test exercise. Wala pa. Wala pa? I gave you the link, di ba? You got the link?
Yes, sir.
So pakisagot lang as I leave it up to you if you want to get a perfect score or not. No, you can repeat it as many times as you want to get a perfect score. If on first try hindi naman perfect, you just list down the yung mga answers that you were not able to answer correctly and then just repeat it na until ma-master ninyo, na? Okay? Okay. So can you do it? If you want to do it, I'll give you 24 hours to do it na i-master lang ninyo. At least try to get one try. Okay, isa lang. Kung ayaw yung i-perfect, okay sa akin, na? Okay, at least you have an idea of what's a patient management process, na? And this will be useful for any types of patients, and it will be useful. I won't say I assure you, but I'm confident that you will find this useful in your future practice, na? Because I've been using this since 1982, no? Okay. Okay. So let's call it a day. Bye-bye.
Thank
Thank
you,
you
sir.
po, sir.
Thank you, sir.
Thank you, sir.
Okay.